Camera rolling and action.
Okay.
What is happening, beautiful people? Igama lam nguSiphile, and welcome to another episode of Writings on the Wall podcast. Today I have a special guest, Professor Veronica Ntsiea, who is amongst many achievements and accolades, a holder of a BSc, an MPH, and a PhD, currently holding a position in the University of Witwatersrand as the head of the physio department. Is that accurate?
Yes, it's accurate. The BSc, specifically BSc physiotherapy.
Yeah. Oh, yes. So BSc, MPH, and PhD within the space of physiotherapy.
Yes.
Prof, welcome to the podcast, and thank you for honoring my invite.
You're welcome, and thank you for inviting me. It's also a pleasure for me to be a guest here.
It's quite nerve-wracking, but I'm excited, I think, for the conversation. I already gave a brief idea when we spoke on WhatsApp of what the conversation will entail. But before we get into that, I think more than anything, I just want to find out, amongst all these big achievements that you have, I mean, you're holding quite an important office, but in all the accolades and all these achievements that you have, which of them do you hold close to your heart? Like an achievement that maybe other people might not consider to be big, but you say, throughout your career, you're like, this one is one that I really hold close to my heart.
Yeah, for me, it would have to be the first degree that made me enter this space.
Okay.
Even though in terms of achievements, the latest one, when I say degree that made me enter the space, I mean the BSc physiotherapy, because I wouldn't be a physiotherapist if it wasn't for that. But then for today, because the current promotion to full professorship, which was in May this year, for me, because it's current, and it's something that some people can go into academia and even retire without reaching the level of full professor, maybe just going up to associate prof. So for me, that's something, when it happened, I didn't, I almost cried when I got the results, because I was standing there. You submit a portfolio, they go through the portfolio, it goes to the next level of the committee, and the next level you have to stand outside, because then you have to answer questions should they need clarification about your research or international standing. So for me, when it happened, the move to full professorship, it was like,
a special one.
Yeah, this is special. And I always wish my father was here, even though he passed on 1991. This is that moment when I was thinking, come and see your daughter.
Yeah. Look at what she's able to achieve.
Yeah, because he passed on when I was in first year physiotherapy. Yes.
So you never got to see, even with the first one?
Yes, not even the end of first year. It was 3 months into registration. Yes, so then, that's the greatest for me.
Those two. And then for anyone who doesn't understand, I think, the field of academia and, physio in general, what is the difference between an associate professor and a full professor?
Okay, it varies between universities, but the primary thing is the level of research, because at VETS, where I am, for you to get to associate professor, you need to have at least 20 publications. You still need and at least a PhD student who has graduated under your supervision. But then to move to full professorship, it's at least 45 publications. But then you have to have good international standing, and there has to be, because they contact the international reviewers who can attest to the fact that you would be the go-to person in that particular niche. And then at VETS, you also have to be rated as a established researcher by the NRF, National Research Foundation. So then I got my rating long time ago. So the rating was not a major hindrance to me getting to full professorship. It was getting to the international standard. And according to South Africa, especially, I know, especially at VETS, I always said international should be international, but here international is outside Africa. So even because I had collaborations with colleagues in Nigeria, then they'll still want you to be outside the
of
region. So Africa would be the region. So I was still building my international presence outside the region for me to get to a stage where, in addition to the publications, I can also be recognized as having good standing internationally before they could even look at the documents.
And when you got into this profession, I think, like you said, the first special one, I think, was getting the BSc,
Yes.
the original. Did you ever think you would get to this point? Were you working towards this, or it's something that found you along the way?
I was not even thinking that I'll do a master's. I graduated and I wanted to be a sports physio. Okay. I thought, the glamour and being out there, traveling with the teams. So even when I went for the interview for my first job at Tembisa Hospital, during the interview, I told them, I'm here just for 1 year. After 1 year, I want to be out there in sports. And at the end of that 1 year, my HOD came and said, okay, what are you saying now? I said, no, I'm not going anywhere.
I'm staying.
I'm staying. Then I stayed for 6 years there.
And
Tembisa Hospital, yes. And that's where my love for stroke rehabilitation started. Because as a student, my love was in sports. And stroke was not an area I was interested in. And mainly because, as a student, you only see patients for 4 weeks. So,
5 weeks,
you don't really see meaningful results. So at Tembisa, that's where my love for rehab, stroke rehab specifically started.
You got to experience. And we're gonna, and that's the main conversation that we'll be having today, stroke and mostly disability. And the reason I remember when I texted you, because I'd be doing the podcast for a while, part-time, here or there, I'll do the odd episode. But there was a day I was on social media, and then I saw a story of this young lady, very young, I think about 21. She had a spinal cord injury. And she was sharing that the day before, literally, she was fine, doing activities, and then after that, she was in hospital, and now I think she's a C7.
Very high.
It's quite a high spinal cord. And when I was interacting, I think, with the comments and following up on a little bit of a story, I thought to myself, this is such a big thing. Disability is such a wide, misunderstood concept. It's very common because it can happen to anyone. Yes. Right? Spinal cords trauma can happen to anyone. And now mostly with stroke can also happen to anyone.
Any age.
Yes. Because at some point we used to associate it with older people, but the more I was engaging, I think, with the comments, I realized how firstly misinformed people were, because some of them didn't understand what was happening. But secondly, how people are actually willing or have the appetite to be educated and to understand everything that is happening regarding disability. And so I thought, the best person I know that I would want to have a conversation with, someone who has similar passion, which is stroke and neuro, was yourself. You have the expertise, you have the years under your belt, you have, full professorship.
Yes.
So, and I really just wanted to invite you to the podcast, have a conversation about your experience as a physiotherapist and your experience in academia, what's currently happening, the misconceptions and all those finer details. But before, again, we get into those nitty-gritties, I think I just would like just for you to paint a little picture, taking us on a ride of how you even got into this physio. Mine was accidental, and whenever I tell people this, they say, what? I say, I didn't plan to get into physio, but I found the love while I was in there. So for you, how did you find physio and the journey, just a brief journey of how it's been for you?
Accidental as well.
Okay.
When I was in high school, I didn't know anything about physiotherapy, had never heard about physiotherapists until I was at university. So I went to university with the intention of becoming a clinical psychologist.
Okay.
And when I was at university, like I told you earlier, 3 months into my studies, my father passed on. I'm the firstborn. And my mother was also not working. My mother is deaf. During those days, they didn't have job opportunities for people with disabilities, even though hers was speech. So then I thought, what's going to happen? Clinical psychologist, you need to have a master's before you are recognized as a clinical psychologist for practice. And I thought, I don't have the luxury of being at varsity all the way up to master's. And so I must look for a 3-year or 4-year degree. And as I started looking and asking around, I heard about physiotherapy, occupational therapy. I was at Medunsa because everything was medical or health professions. So, but then for me to gravitate towards physio is I identified more with what physio was all about. And I also must confess, I always confess this, that I also heard that they were getting paid, the students. So, and I thought, what? Okay, this is not a bad profession. I can do it, yes. But then the fact that every month I get paid, and this person was telling me, was even showing me their pay slip, I think it was 800 rands, and this was 1992. And I'm thinking, wow, this is a lot of money. I'm in, but then I still had to go through the HOD because I had not applied, because I still completed my year 1 and I was in year 2, trying to figure out exactly whether I still continue with that psychology or not. And then the HOD eventually gave me an opportunity. I did meet the criteria, but the fact that I had not applied and the fact that she was more worried, she kept saying, I know your type, you're going to come here, do physio, and the next thing I'll be hearing that you're doing medicine or you've exited physio. And I said, no, I do like, I have tried to ask around. I do like what they say they're doing, and I would love to be a physio. And yeah, I've never looked back. And I think, I think if I had to start afresh, go back to high school, I'll still choose physio and I'll still choose neurorehab.
So, not to cut you, Prof, was the pay thing real?
Yes, only for Medunsa. Because during apartheid, Medunsa was created for Black people and for people, and it's people who are disadvantaged. Yes, so then if you're doing physio adverts, you are not getting paid, UCT or Pretoria. So it's only those who are doing physio at Medunsa, because it was to assist the students with their needs. And and so it was OT, physio, and the nurses. I don't know of the other professions, because you spend time treating patients in the hospital. I don't know why it wasn't there for the medics. I think maybe it might be that some of the medics, the bursaries they had also had pocket money, so they had better packages. So maybe that's why then they had this salary. By the time I graduated, I think I was earning 1,200 per month. Yes, I bought a fridge at home, TV. I had deposit to buy my first car.
I wish this was still true for everyone now. I'm sure we'd have.
It stopped maybe 2 or 3 years after we graduated. Yeah.
And then there was a lot of money back then.
It was a lot of money because as a qualified physio, my salary was 2.6. So just to put it in context. So in 1996, entry-level salary being 2.6, as a student qualifying earning 1.2, it was a lot of money. Yeah, the 2.6 quickly changed to about 4.2 after they looked at our salaries. Yeah, but with that amount, because I bought a flat, my monthly installment was 1.1 with a 2-bedroom flat with a sitting room. So it's the cost of living then. My full tank was 90-something rands. So it was a lot of money.
It definitely was. And now coming to this again, you see, with this accidental thing that happened, partly why mine was also accidental is because I didn't know what physio was. For me, I didn't know to the point where I was studying physio in Cape Town, and I had no idea why I was there.
While you were studying?
While I was in the physio. And I always make, because my sister, so I had applied to vets actually in matric. But it was for medicine, because at the time I thought I wanted to do medicine, but for medicine and some engineering. And I got rejected for everything in June.
Okay.
So I was heartbroken. So I thought, you know what? I'm not going to apply to any other universities. Luckily, my sister inquired, I think about August, September, that where have you applied? What's going on? What's the plan for next year? And I was like, I don't really know because Vets rejected me. And then she applied in Cape Town for me. So she did physio first option. And
She applied for you.
she applied for me.
Okay.
So yeah, she just applied and she did physio first option. And then I got the offer that I must go to Cape Town. And I was like, okay, Cape Town. I like the idea of Cape Town. So I just went to Cape Town. And while I was there, I was basically figuring out what this physio is. Because I was like, hey, we come here, we do anatomy. In first year, it's not very clinical. We do anatomy. But I think a lot of the biggest reason why I didn't know what physio was because we didn't have exposure to all those professions. We're from a very small town. So we just knew medicine, doctor, lawyer,
Dentist.
accounting, even dentist we knew about, but not really how to get into it. So for you, what's your background, where are you from, and what contributed to you not being aware of this
physio.
profession?
Yeah, I was born in Seshego in Limpopo, and then my parents moved to Liboakom. It's town. The areas I'm talking about are townships, so one would have thought, okay, maybe there were physios. There were no physios there. And then I went to high school in a rural area, but it was a boarding school. And then they eventually did the career guidance, and they brought people to do aptitude tests, and then they were telling us, they told me I could be a psychologist, social worker, or teacher. That's why I ended up considering clinical psychology. So that, but then when I started physio into my second year, I found out there was a physio in Liboakom, the township that I came from. So during my school holidays, I went to her practice because I heard about her from the physios at the university, from the lecturers. When they say, oh, you're from Liboakom, there's Jolene, or do you know about this physio? Then during school holidays, I would go check out her private, she was in private practice.
Okay.
And then that's how I got to know more about what physios do. Even in my second year, I requested to go work at Mankweng Hospital. As a student, during my holidays, I had little apartment in the hospital for a full month just doing grade 3 education. So, but the number of physios were very few, and they were not going out there to the schools to educate learners. So at the moment, we intentionally making an effort to go to the schools to make the learners aware. But at VETS, you wouldn't have made it onto the VETS program. Okay, maybe then. Now we don't accept any student who hasn't visited a physio practice or hospital, because we don't want anyone here who doesn't want physio and get to know about it as they go. And then maybe third year, when they start clinicals, they said, no, this is not for me. So it's better to know right from the onset, because most people are not well informed about physio. And some think you are like a medical doctor, and then they come here and they realize, no, you are a rehabilitation professional, but physio is a first-line practitioner. You can still see the patient directly from their home, assess, diagnose, and treat. But then people think, okay, when do I do the operation? When do I prescribe the medication? So then they realize, no, that's why I would want a person to be exposed.
To do the shadowing.
Yes, but I didn't get shadowing, and I think if I got shadowing, if I shadowed the English, if I shadowed, I would have had more information about the profession. Some of the things I was learning as we go. And medicine, my father wanted me to do medicine. I have this fear of blood. But even my matric results, I wouldn't have made it into medicine. But with my first year results, I have qualified to go into medicine, because one of our anatomy lecturers, when I went into second year, was like, you got 100% in biology. All my marks were like 80s. And chemistry, physics, and everything was like A+. And it was like, why don't you cross over to do medicine? And I've never been comfortable in that space. I take my hat off for people who can deal with trauma and work in a situation where there's blood, even though I found later when I was at Tembisa Hospital with Ben's unit, that sometimes they say, go and mobilize the patients with the bandages off. But I must say, I managed to not do that because there were physio assistants and they were very good. So every time in the ward, when I was supposed to do mobilizing with the bandages off, it was the physio assistants who were doing it, and then I would still assess and I'll still give input. I am not comfortable working with blood, but I know there's a lot of medical doctors out there who are also not comfortable. Then they found their way of streaming, maybe going into administration. We see them in public health. But the main thing is, for me, physio, if I had to go back, I'll still choose physio. I'll then still choose neuro.
What about physio? Because you're saying you consulted while you were in varsity, ne? Where you're speaking to the people.
Yes, the students.
Aside from the money, what about, I think, the profession spoke to you on a personal level? Because I have this belief that, look, physio it's a very intimate profession. I think especially when you are dealing with patients, and even if you get into academia, there needs to be a level of caring more than just about the theory that you need to have. So what about the physio spoke to you that then drew you in to say, okay, come through, kept you in there up to a point where now you have found this love for neuro?
Yes, like I said, I didn't like neuro as a student. So what drew me to physio was definitely not neuro. It was when they said exercise. Because in my first year at university, I was into athletics, aerobics, but then they said we use exercise, muscle strengthening to improve the person's mobility, to improve the person's range of movement, strength, and assist them to be able to go back to functioning. And the example that they used was a person who's not able to walk. If you do some assessment and identify exact muscles that are weak and you strengthen, they may be able to walk. And another one that attracted me was the electrotherapy. When they spoke about electrotherapy, I thought, oh, this is, wow, machines, fancy. They say interferential, ultrasound. I thought, oh, I can do this. And they said, this is for management of pain and even strengthening of muscles, because some of the modalities we had then, which we don't have now, we do the Faradic stimulation, get muscle strengthening using those stimulations. So for me, that, it resonated well with me. I thought strengthening exercise, improving quality of life using exercise, and being with, working closely with the patient. But if I knew about neuro, maybe I wouldn't have done physio. I must say, neuro at that time, it was people with stroke, people who are weak, and the drooling at that time. And I thought, no. But then the focus there was just looking at orthopedic sports, and then that drew me in. And then if I was going to be told about neuro, and I thank God that it didn't come across. I found out when I was already in, and then I didn't like it. But the spinal one, I enjoyed. I enjoyed spinal because seeing a patient struggling with rolling and being able to roll, and the transfers, playing games, and when we did games with them, it was still leaning more towards sports. In neuro, I didn't see results. By the time I mean brain lesions. By the time I started the block and left the block, neuro was different then compared to what we're doing now, because we were first focusing on sitting straight, posture, and then making sure we manage the tone. So it was taking longer to get to function than we do now. So now, if I was to be a student now with the kind of research we have, and knowing that we can do a lot of activities from the onset, even if we are not yet into proper alignment, the neuro we do now is much better. We see results quicker. So the neuro I'm talking about, it's then when we're still doing weight bearing, sit straight. And by the time you get everything right, it's 3 weeks, it's almost the end of the block. You have to go. So, but now with our students right from the onset, if they have the need for strengthening, for balance re-education, for getting up and walking, you're correcting the posture while they're up and walking, but there's more activities right from the onset. So even within a 4 weeks block, the students can see some results.
And then fast forward now to Tembisa You were there planning, I'm going to be here for 1 year and then I'm going to be gone.
Yes.
and you're there and you get exposed. That's where the neuro,
my love for neuro
comes
started.
from.
Yeah.
How do you go from, okay, I mean, yes, it was time limited as a student, but now what about it? You're like, okay, this one, this is where I want to be.
I start at Tembisa, and most physios don't like being in medical wards. Then, because the chest is fine, but then most of the stroke patients that you find them there. So then I was given medical wards, and I thought they'll give me maybe ICU and some orthopedic ward, but the physios, there were 2 physios who were working there, and the 2 of us knew coming in. So the 2 of us were given PENS units, the medical wards. So then every day I was going in, we'll do the chairs, the TB cases, but then whenever I would have a patient with stroke, there were always patients with stroke in the wards, and I'll bring them to the department. The porter will always bring them to the department, and then get to the time of discharge. They come in as outpatients, and I'm imagining this person who was semi-comatose, and we're struggling with rolling, coming to physio department, doing line to sitting. Now he's standing, now they are coming, now they are working with a quadrupod or whatever device they're using. And then then I realized, we're making a huge difference. And people were coming back to say thank you. And then I realized this is where I had a sense of purpose. Every time I woke up, I'm looking forward to seeing that patient. There would be the chest, yes, the auscultation, the percussions and all of that with other patients, but I was always looking forward to seeing what we can do more with the stroke survivors and even the spinal patients that we had in the hospital. But it's spinal, when it's complete, we can do more up to a certain level. So we're not able to get everyone out of the wheelchair. But at least we're able to get them to a point of transferring. They transfer into the car. They're able to do therapeutic standing. But the one that made me focus more on the ones with stroke or brain lesions, even though we didn't know then that it was more of the neural plasticity, the more they practiced, the more they improved. The more they practiced, the more they got better. Obviously, the more severe ones won't go back to what they were doing before. Yes, but the key thing is that's how I eventually fell in love with neuro. A few years, I think 3 or 4 years down the line, I opened a private practice. I went into a 5/8 post. So half day I would go see my patients in Tembisa, Tlama, and 2 days a week I would drive all the way to Secunda, to Mbalenhle. And then I was seeing more backs. And then in Tembisa, there was a football club, Tembisa Classic. And then their soccer players would also come to my practice for treatment. And then I realized that some of the people don't listen. You tell them, don't play this weekend, this injury, please don't. Yes. I need to see you again. And then they come back and it's severe, they've played. And I was not looking forward to seeing them. Whenever I had an appointment, I'm thinking, maybe it's worse, maybe they played. And then the backs and necks I'll be treating. And then those who had medical aids, the money was coming in, but I was not fulfilled. Because I remember one soccer player telling me, but they'll pay you. I said, no, it's not about the money. When I wake up, I need to know today we are going to do 1, 2, and then next week I know we are progressing. Then I get fulfilled. So then that's how I realized even my love for stroke rehab in the hospital got grounded. Even in the practice, I started marketing more on the neuro side. And if a patient came in, and the secretary would phone and say, a patient, and I said, if it's a back, refer to a physio, there's a physio 3 streets away. So then, but eventually, maybe you wonder, why did I leave that and find myself here?
I mean, that is the next question. But I think it's quite interesting that you're mentioning the fact that, like you're saying, sports physio. And even now, I think the conversation has not changed in terms of there's a lot of money in sports physio. You can travel, you can see all these patients, and it is a field that is very popular. I think as physio, whenever someone thinks of physio, they usually think something sports related. You're gonna be working for a soccer team or etc. But I think when it comes to then the other side, where it's neuro, you mentioned And people that are in sports are fulfilled, you know.
Yes.
But you found that sense of purpose in neuro because of just the field, you know, and how it's structured. Now it's the curiosity of how does it then progress to academia, where you're like, hey, I want to pursue my studies now I want to know more. In someone, I was actually speaking, I don't know who was having a conversation with, and I was asking just questions. And they said that's how someone usually goes into academia, because when you ask too many questions and you don't find the answers, you want to go find the answers yourself.
Find out, yes.
And that's how you get into. So how did you transition then into academics? Because it can be, I think camp is daunting when you think, I'm leaving my patients and I'm going to go now into a space where I'm not getting that one-on-one interactions.
For me, again, accidental move. It was not planned.
Okay.
I was going about treating my patients, making money with, in those days, the private practice in Mbalenhle next to Secunda, next to Sasol, doing well, and then thinking in the long term, I'll be moving into full-time private practice. Then I got a call from the university. So, yeah, vets.
Okay.
Then I got a call. They said, someone recommended they said we should contact you. Let me be specific. They said, Linki Molatudi, who was your lecturer at Medunsa, has recommended you. We need to have a person to come coordinate the diploma. They're starting the diploma for the physiotherapy technicians. And they were very late because it was towards the end of the year and they needed to have intake. It was 2001. They needed to have first intake 2002. So then they were sort of headhunting now because they didn't have time. Yeah, so then I said, okay, it was Prof. Stewart who called me, and I thought, okay, so if they think I would be able to cope in that position. They said, yes, they thought you'll be able to manage this. And then I remembered when I was a student, I did tell her, in passing, that one day I would want to be in academia. And that was it. Like it means it planted a seed. And then I'm going about my life. I even forgot
about that.
So then that moment, that conversation that I had with her, I immediately remembered. And then I immediately even got excited by the fact that, now I'll be working at vets as an academic. And I accepted to come for the interview.
Okay.
And accepted. And then when they showed me the payslip, it was like a huge drop in income because they can't compete with private practice income. And I was thinking, okay, I'm in, and they promised me I'd still be able to see my patients. Obviously, that was not going to be possible. So I signed everything when I was in, and I realized when I was already in, traffic to travel from Kempton Park, I'm not coping with traffic. I'm not able to see my patients in Tembisa. And I'm not able to cope with this little money that I was getting at the time as a senior tutor. I was coming in as a senior tutor. But then deep down, I thought, this is where I wanted to be. And because you move up the ranks, and as you move up the ranks, your salary also increases. So that's how I found myself here. But it was for the diploma. To coordinate the diploma, the 2-year diploma meant I had to teach everything. It was not just neuro, but everything I believe was like divine alignment, because just 2 years down the line, the neuro lecturer resigned. So there was a neuro post. And exactly the same time, the Minister of Education, then Minister Kada Asmal, announced that the universities are no longer allowed to do 2-year undergraduate diplomas. So we had to stop the diploma. And at the same time, there was an opening in neuro post. And within the diploma, I was also indicating that my interest is more in neuro. People in cardiopulmonary, like Prof. Van Aswegen, would still teach cardiopulmonary and other things. I would focus more on neuro in the diploma and other things. So that's just how I got myself into the neuro post. Yes, and now in the neuro post, because now I'm a full academic and wanting to move up the ladder, you needed to do masters. Yes, that's when, but then I thought, I'm not doing MSc physiotherapy, I need something different. I went to the School of Public Health, decided to do masters in public health. It had hospital management, and which means I was not yet sure whether I'm here or leaving. Yes, but then when we got to research, I said, I want my research to be in stroke rehab, and they said they don't have supervisors for that kind of project. And I said, I can ask from physio department if you can allow staff from the physiotherapy department to supervise my project. So I did my master's in public health, my research in stroke, supervised by 2 physios, Prof. Stewart and Prof. Mutsi. And then from there, it was PhD. Because it's a natural progression. The culture, I think the culture at vets also helps because it's expected of you
to go further.
To go further, but they don't dictate what your research should be in. For my master's, I was looking at functional outcome of the stroke survivors at the time when they are discharged. And then, so when we looked at most of the stroke survivors, even with the students in the hospitals, we realized they get discharged. We don't know exactly what eventually happens to them. And some don't return to work. And if they don't return to work, why are they not returning? So then I thought, let me do my study, my PhD.
The questions.
Yes, because we want to answer questions. And if you can answer them within a degree and you do it for degree purposes, why not? So, and I've always said, for us as academic, studying can be considered a job description. We study for free, first of all. We have no excuse. And we can use our working hours to study. Yes. So then I worked on that project and we did an intervention program to assist stroke survivors with return to work, focusing primarily on work ability assessments. And when I started, I struggled a lot because some of the occupational therapists kept saying, no, this is not physio.
This is scope.
This is OT. And then I had to share the resources, even some of the prescribed books for voc rehab and return to work that were written, some by Canadians, and those were physios. Then I said, I'm going ahead. This is physio. And I checked the HPCSA, our Health Professions Council, scope of profession and scope of practice for physio. And it indicated that we can rehabilitate patients right up to the community, the home, including industry, which is return to work. So then that's how I found myself doing that. And then after PhD, obviously, you continue with the research. And I had masters, about 20 master's students, some not in Europe, but mostly in Europe, and the PhD students.
You've now touched on, I think, your master's was on the functional outcomes. And you know, went on to try to create a program around it. And I think one of my, because in my experience, I was in primary, so my introduction to physio was straight into primary. Again, accidental. I did not apply to be in primary healthcare. I was just, it was not even in any of my options. You know how you choose for ComServe? I was just placed there. And I remember the first year I was like, what is going on here? And they're like, you have to do home visits and this. And I said, home visits? You have to go to someone's house. And they're like, yes, you're going to be traveling, you know, I mean, this, as an Alex. Go, Alex. I'm like, yo, okay, I don't know. Me, I'm not even from Joburg. You know, this is new to me. But fortunately or unfortunately, that year, I didn't have any exposure to home visits. But then the following year, I went to Soweto, which is where I got to experience, I think, community-based rehab. And a big part of it was reintegration. I think a word that we always use was reintegration. How do we best reintegrate patients? They go to hospital, go to district, and then they come to us. But what happens after, like you're saying, what happens after they get discharged? And I mean, we did put some things in place, but I think the biggest struggle that I had, and even now recently, one that I realized is a lot of the information is there, right? The beautiful programs taking place, there's beautiful research that is accessible to a lot of people. However, there's this big gap between where the information is and the people that are benefiting from them. So either being therapists to utilize them or the patients themselves that, okay, left hospital, have been discharged, where to from now? And I think that's why I wanted to have this conversation mostly is this breakdown of communication. I think maybe from your experience, where do you think it's coming from? Where there's beautiful work being done, but you know, in academics, there's therapists on the ground, but they don't accessing this, and now subsequently the patients themselves don't get to reap the benefits of this beautiful research happening. I think in the country, where do you think that breakdown of communication, or I don't know, the gap is coming from?
Yeah, I think it's mainly where we operate in silos, where and again, if you do a master's because you want to be confirmed in a lecturer position, and you do a PhD because you cannot be a senior lecturer without PhD, it means the focus is not on translating the research into practice for most. And others just do masters to answer a specific question in their practice, which is better because then they can apply in their practice. So the major issue which we've tried to address now in the past few years, and even for stroke rehab, what helped was the stroke working group where we served together. It's that if you have stroke survivors involved and you have policymakers involved right from the onset, and you're doing a research project to address a problem, a real problem in our country, not something that was identified as a gap from literature search. Because as I complete my study, I'm going, okay, from this study we realize that the patients are not being reintegrated, they are being discharged early. And then the next study is, okay, let's look at community reintegration. This now we are doing with another student. And then they are not reintegrated. But if you look at it, the patients are not involved. So it's us making those decisions. And then we're also thinking, okay, let's do a return to work program. We do a 6 weeks nicely packaged return to work program. Patients not involved, policymaker not involved. So at the end, we sit with projects that cannot translate to practice because you still have to convince policymakers that it's actually important. So from now, okay, when I say now, past few years, we try to do research that addresses the problems that have been identified in the community, either with the stroke survivors or with the clinicians, not just academics and researchers. So if we work together with those who are working with the patients and also consult with the patient, we've just returned from the World Physiotherapy Africa Region Congress, which was this over the weekend in Cape Town. And most of the key messages were we have to involve the patients and their caregivers, and we have to involve the policymakers, not when we are sharing results. We have to involve them when we are conceptualizing, when we are thinking, this is the kind of research we'd want to do, bring them to the table, let's all discuss and check if this is actually needed, or maybe we may need to modify, and maybe if we do that before, it will translate into practice, it will close the gap. And we've always said we have a lot of research that's been gathering dust. That's when we're producing books. Now it's, I don't know, it's electronic, so it's just sitting there and occupying space. So we're moving to implementation research and making sure we do relevant research for our context.
Well, and what are some of those problems I think identified within I think the stroke domain? Some of the challenges that we've identified that we are now trying to find solutions for with the research.
Yes, so the main one is if a person has a stroke already and the length of stay in the hospital is short, the average length of stay for most of our big hospitals is 6 days. So, and that's from a study by Professor Mudzi, which was done at Bara with more than 200 patients. And then, but the district level and maybe regional level, it might be slightly more days. But the main thing is most patients at the time of discharge, they still need more rehab. So then they get discharged and they don't have access to rehab facilities in the community, either because where they're going, there are no physiotherapists or occupational therapists or rehabilitation staff members at the clinic, or if they are, maybe they see them once a month, and you cannot have meaningful results if you are being seen once a month within your first 6 months of stroke, which is the crucial period for recovery. So then they miss out on that. So what we're looking at is creation of self-responsibility programs, training of caregivers, making sure that even though, because we don't have control over the posts, if they say there's no money, and we can keep writing. So if there's no money, so we sing research that looks at alternative approaches. So training the patients, and now with the smartphones, going more into tele-rehab. We have those who are working on research that looks at tele-rehab. But again, patients going home, some of them are not able to come to the clinics. There may be rehab staff at the clinic. You need transport.
Yes.
Or then money to hire a car. Uber, some of them would use Uber, but you need money even for that Uber. A local taxi where they would pay local might be cheaper, but then it doesn't come all the way to pick them at home. If it does, it's a special. So they have to pay far more. So it's access in terms of transport, access in terms of lack of rehab professionals to do this, to offer the services. So then we focus more on self-responsibility programs. We are developing, there's a PhD I'm supervising, though not in South Africa at the moment, a student at University of Kathmandu, because the challenges are similar. So we're developing a program that patients can follow, and we can also use some of the videos for them to follow a step-by-step exercise program that is designed specifically for them. And then also designing things that allows you to do follow-up. With smartphones these days, we can do a lot, and with the apps that we are getting. The one in Kathmandu is actually development of an app that is going to help with designing and monitoring activities for the patient. But for our South African context, when we're saying apps, you still need data. Because people have smartphones, but then they tell you, yes, I have a smartphone. I have just enough data just for WhatsApp messages. Don't send me videos. So then in that case, you can still send SMS, can still send text, which is still better. Because then they can also inquire about the stage of rehab, where they are, and then also training the caregiver. But the caregivers in South Africa, when we did some studies in Soweto, and even in Potchefstroom, we found that there is a lot of caregiver strain taking on the responsibility of looking after a family member. I've experienced that when I was looking after my mom when I had to bring her to my house. She didn't have stroke, but she, towards the end, had mobility challenges. I know having to look after a person at home, go to work, come back, even if you have a helper, it's your family member, you still get involved. So we then look at caregiver education programs where they can learn to reduce the amount of support and promote self-responsibility.
You're mentioning such an important thing, which is caregivers, right? And I think another contributing factor, I think, to the caregiver strain, this is just from not observations from practice, is that a lot of, in our settings, a lot of the times, the role of a caregiver isn't one that is discussed. It's one that someone just assumes. So if a patient has a stroke, they get discharged, the automatic thing is the person they're staying with becomes a caregiver.
Yes.
Whereas we've never had the conversation, I think, from a clinical point of view, where we speak to the caregivers to say, okay, this was your mother, or this is your mother.
Yes.
And you had these dynamics that already existed between a mother and a daughter, but now we're moving towards a stage where you are now becoming a caregiver to the mother.
Yes.
And there's a shift that is required for that to take place successfully. And we've seen it, I think, in practice, where someone will come with a caregiver and the caregiver is just sitting, and you wonder what exactly is happening. And the reality is that this person was my husband or is my husband, and now I have to be their caregiver, whereas there's in other places or contexts where there's a caregiver trained to come and become a caregiver.
Yes.
So it can be a bit easier then, but I think when you assume the role of a caregiver and the role of a personal relationship, it can be quite tricky. And we found that to be a big reality in practice. But how important do you think it is to move the attention? I mean, there is an empowering part for the patients, and I want us to get into that, but of the focus being around caregivers, because we do neglect. I mean, from a clinical point of view, we do neglect caregivers. We're just like, oh, they're there. They must watch. They must do. If they're tired, they're just being lazy, and we become impatient with them. But how important is it to involve them from, I think, the onset of.
Yeah, you mentioned one important thing, that we shouldn't assume that they are the primary caregiver, because they could be bringing them to the hospital, we train them, but maybe they are not the primary caregiver. And the issue of drawing a line between a family, they say if you are a spouse and you're looking after your partner, your husband or wife, after they've had stroke, it's detrimental to the intimacy, because you now relate as caregiver patient. You don't relate as husband wife. So they say whenever possible, we should avoid having a person who's a spouse playing the major role of being a primary caregiver. And others would say, no, I want to look after them. It's my wife or it's my husband. They say, yes, if they do, it must still be limited. It mustn't be full role, a primary caregiving. And I remember with my mother, she was getting physio services from another physio, and then the physio will tell me, this is what you need to do at home. And obviously, it's things I knew. And when we get home, and I'll be telling my mother, it's time now, time to do the movement. And she said, no, I'll do it with the physio at the hospital. And I said, no, and I'm actually the physio. So it was a mother-daughter relationship, struggling to break that barrier. And I had to listen to her, my mother saying, no, I'm not doing it. And then have to see her cooperating so well with the physio and doing and standing up and doing the activities. That's when you realize we need to have a person who's a caregiver, who is not necessarily a family member, but it can be expensive because people don't do it for free. But in some instances, if it's another family member or a neighbor who can do it, but not the key people who stay with that person daily, it's the same as driving lessons, being taught to drive by your father or mother or brother or sister, different from being taught by the instructors. So it's the same principle. But then another thing for the caregivers is respite care, because there are those who don't really have choice. They have to be there, be with their family member, but other family members must create time to relieve them, even if it's for a day, for them to just go out and have a day or full weekend without caregiver responsibility. And most people forget about that. They'll come visit. They are coming to visit, but they leave you with the person that you're supposed to assist. But nobody ever says, this weekend I'm coming, I'm staying over for the full weekend, you can go and maybe have a weekend or go visit another family if you don't have money to go for holiday. But there's the importance of time out. It's helpful to reduce the strain on the caregiver.
I have a hypothesis. I don't even know if it qualifies as a hypothesis, but it's something I'm thinking about, and it's just from the clinical experience. I think partly from the clinical experience is just understanding that I think when it comes to rehabilitation, the physio alone can't do everything. That's the first part, because there's a lot of contextual, and you're bringing them up, a lot of contextual factors that come into play in terms of the functional outcome of the patient. They're not just coming in because they have a stroke or a brain lesion, or they're not just coming in because they had trauma and experienced spinal cord injury or whatever. There's a lot of factors that come into play. They are now a person that is living with stroke. They have to accept a new reality. And from there, they get discharged into a home environment. But that home environment does not just exist in isolation. It exists within a community. And you made reference to like neighbors, accessing neighbors and family members and stuff. And that just goes to speak on how important it is to factor in the environmental factors that contribute towards the functional outcome of a patient. And that's something that I've been quite interested in. And I've come up, I don't know if it's new or whatever, but I'm working on this concept where I want to explore disability as an experience more than it is a condition, like the medical condition, like a stroke. So the person has a stroke, but then the experience of the disability is mostly influenced by all the other factors, like in the ICF, the environmental, personal, etc., etc. And for me, I mean, I don't have the research background for it, but in your research, you know, how much impact does the environment and the society have towards the functional outcomes, one, and then secondly, what is it that we can do to try, because there's a lot of misconception, again, back to what I was speaking about earlier, where people don't understand these things, and because they don't understand them, we are unable to manage them. We had cases in clinic where a patient comes a year later after a stroke and you ask why, and they said because the first few months they thought it's a neighbor who sent me this thing. And we can be frustrated at times, if you had come in that month, you know, we could have made so much progress. But we can't blame them because they exist within a community that is also misunderstanding of all these things. So what how important are these environmental factors contributing to the outcomes? And then secondly, what is it that we can do to at least include everyone, because until it hits you sometimes, it's irrelevant. Like a stroke is there until it hits someone close to you, or now someone says, actually, you are hypertensive and so forth.
Yeah, I think the main thing is constantly sharing information, and what we do, because I know is it still, are we still?
Yeah.
And
Yeah. And it's
yeah. Okay. So the main thing with this, our students, they do radio talk shows. Our students in rural, in public health, they do radio talk shows because most people listen to radio. But then we also need to do, I know when it's at the clinic, it's too late. You want to talk to the people to do primary prevention. But then a person who's had stroke can have another stroke because others are not even aware.
Yes.
That it's not like I have a stroke and that's it. You can have a second and a third stroke. And the fact that hypertension is the most common cause. And hypertension is a silent killer because a person can be hypertensive with very high blood pressure and be walking around and not knowing that they're hypertensive until they have an experience either screaming and pushing the blood pressure even higher, and they get a stroke at the time, and they didn't know all along that they were on the verge of just having an artery burst or on the verge of just pushing a clot to block another vessel. So it's educating the community, and we have, I've just forgotten now the name of our educators, Renata and them, the ones that target school children. I just forgot that they are with us on the stroke working group. My memory.
Yes.
Yeah.
Yes. The Angels Initiative.
Yes, Angels Initiative.
Yes.
I think we need more of those because with the Angels Initiative, they realize that reaching out and educating young children, like primary school children, then when they are in the homes, they constantly reminding family members about what's important and what needs to be done. And then also making sure people are aware that stroke most of the time is caused by hypertension. It can be other things, the people with cardiac diseases or other underlying medical conditions that make it easy for them to form clots, or other medical conditions that make it easy for the vessels to burst. But the key thing is making people aware that this, especially these days, because it affects even young people. And non-communicable diseases, most of them lifestyle related, affecting people even up to the age of 20. You were talking about a 20-year-old with spinal cord injury, but you do have an 18-year-old with stroke. Yes, so I remember most of the time the 18-year-olds or 20-year-olds with stroke would have been related to cardiac abnormalities, but these days you do have those with hypertension at the age of 30, age of 40, stroke related to hypertension. So educating people and making sure we prevent stroke, the primary prevention, ideally that's what we'd want. And unfortunately, we also still looking for funding for us to go out and do our specific, when I say the stroke working group and us at Vets doing primary prevention, we've just been focusing on secondary prevention. Those who've had stroke. But then the main thing is to also create awareness within the home that a person who's had stroke, this is now something else, a person who's had stroke can still engage. They can still go to family gatherings because there are times when they have a person who's had stroke, they are going to a family party, they leave them. They are going to church, they leave them. So they can still engage. And any person with a disability, even if we're to not just focus on stroke, any person with a disability, if there's no contagious disease or there's no risk for them to be infected when they go out, nothing stops them from being mobile. And at the moment, it's something that started a few weeks ago, trying to see if we can advocate or encourage people who are having Uber cars to also have more mobility assisted vehicles, because there are countries where they have a lot of mobility assisted vehicles. Instead of having people hire specifically a car where they can be wheeled in, a mobility assisted vehicle, an Uber, of that kind, you just call an Uber and then maybe pay extra 20 rands or so, but you know they're just going to wheel you into the car. You go to a shopping mall, do your shopping, come back. So we need to be advocating more for that, because it's environmental barriers that they say a person is not disabled, it's the environment that disables them. And people who look down, because if you are sitting on a wheelchair, we are at an event. That's why I like the standing wheelchairs, but they are very expensive. So you are at an event, everybody's standing, it's a cocktail, people are talking, they talk over the head
person,
of the person, so taking over the person, or even not engaging directly with the person. If we want to ask if they've taken their medication, they are there with the caregiver. They don't have a speech problem, but we're engaging the caregiver. We're not talking to the person. This is disrespectful. And that my mother, I did say my mother had a disability, speech, she was deaf. When we grew up, she always refused to have people talk to us and ask us to tell her what they were saying. She'll always say, keep quiet, keep quiet. They must tell me, they must make a plan. So people had to make a plan to engage her directly and not disregard. So even a person with a disability on a wheelchair, the experiences, we would always want to know their experiences in the community. Most of the time is that they are not seen by the community, and also sometimes not seen by the health professionals who don't engage them, who always assume they know what they need. So I think the most important thing is to make sure we see the person, the Ubuntu principle, and coming from the Sawubona greeting. So we need to see them and engage and then work together and advocate together, and not go and advocate for them for things that they don't even think are important.
Important to them, and it's quite important. It's very easy to step into that. Just in closing, because I know you press for time, but I think I want to ask two things. The first thing is, what's actually happening with these young people? Because I think it's getting attention now where young people are getting strokes because of the celebrities that are getting strokes, and they're quite young. What's happening there? And then secondly, where are we in terms of research, like something that's, finding and something that is going to affect or influence where clinical or therapy is concerned? Where are we in terms of that? And then the other one is, what's actually happening with these young strokes? Just before I let you go.
Yeah, the young strokes, the main thing is, like we say, most of the strokes are lifestyle related, and lifestyle doesn't mean a person is eating wrong food. The main thing is stress can also contribute towards increase in hypertension. I was diagnosed with hypertension. Most people are not aware that I'm on chronic hypertension medication immediately after my husband passed on. The stress, I couldn't cope. I couldn't cope to a point where I reached a point where because I didn't change, my lifestyle was still the same. I would still go exercise. And then the only thing that changed, even my son, because of the stress levels, then we got to a point where we were hypertensive, and then got to a point where we needed to take medication. So people need to be screened. You need to know. I wouldn't have known. I knew when I went to donate blood. And on the day I had to go see a doctor. Imagine I'm a health professional. I'm doing research in stroke, creating awareness, and my blood pressure is very high, and I'm not even aware. So I thank God I didn't drop and have a stroke. And so the key thing is awareness. At the moment, we're trying to work together with everybody who's doing research in stroke prevention, because the only way is if we can have primary prevention. The first group has started, the ones who are working on reduction of salt in the food, in the bread, in South Africa, because that's primary prevention, because we need to operate at a bigger level. But then at individual level, we also need to watch what our lifestyle, because people are extremely busy, and at the moment people even brag about being busy.
Yes.
Who I didn't sleep, who I worked until 4 a.m. as if it's a crown to be that busy, and actually that's increasing the stress levels, not giving the body enough time to rest, and eventually predisposing ourselves to having a stroke at a young age. And exercise, physical activity. In the study that we did, the data that we collected from Alex and Shawelo, we analyzed and looked at quality of life and factors that influence quality of life, and then did a sub-analysis to look at specific items. We found that physical activity Physical activity is not just exercise, going to the gym. With the study that Khaneso, one of our colleagues, Dr. Sekome, the PhD study that he just completed for his PhD, which we got now, like last week.
Oh, is it?
Yes, he's now Dr. Sekome.
Congratulations,
Yes, congratulations, Khaneso. So he's looking at physical activity in the rural community. And you don't go there and say, let's start aerobics class. You can do that, yes, it can work for others. But others work in the fields. It's a matter of doing more and doing more activities that push your heart rate high and doing activities that would help the body cope. And when you exercise, they always say a bigger body that exercises is less risk than a smaller body that's sedentary. So we need to keep moving. We are created to move naturally. So the more we move and watch what we eat and reduce the salt intake and specific stress is a major factor that we don't emphasize, and also try to manage our lives and make sure we rest and we do exercises to improve our coping levels. Yeah, because sometimes people who do exercise have a higher threshold for stress, or they're able to manage without you having to scream at the children. If you've been joking or walked around the block, you come, you look at the problem, you are able to accept and say, you know what, this is not acceptable, but let's sit and talk about it. But if you haven't walked around the block, you might be throwing a shoe at them and pushing your blood pressure up. So physical activity, that's what we will be pushing. And the park, you know, when they put this exercise equipment in the parks, this new project,
gyms,
we thought we'll plug into that and encourage people to participate, but you need transport to get there. So we're now looking more at creating more apps, games. You know, you need physical activities in the form of games, even in the home environment. And in the community, there are those who have support group, but they have to be driven by the survivors. Yes, because if they are driven by the rehab professionals, because we have occupational therapists, speech therapists, nutritionists, or dietitians, if they are driven by us, we are few, we move. So if they are driven by the people in the group, many years ago, there used to be a lot of groups in the communities. And these days, people are sedentary and we don't have groups. And even post-stroke, then people continue to be even more sedentary. So we want to improve mobility. And we want to also focus on advocacy and not just awareness. And now at the conference, we're discussing the Rehab 2030 goals, because the main thing there is we need to make sure there's access to rehab. If I had things my way, we should be having rehab units at each city, not just province, because people can do much better, can improve, and then they can mobilize on their own and creating safe spaces for walking. In our community, the safe space, because, you know, people are worried about crime. So safe space would be where you gather and you say, at 7 o'clock, people who want to walk, we start from this place and we walk. And then also accommodate people on wheelchairs and those who walk with devices. There's a walk in Polokwane, where the guy does the Nyeko, I must mention Nyeko, Mr. Dynamics. He started the walk, the 100-kilometer walk, Polokwane to Zaneng, but it has nothing to do with disability. But what I like is they included people with disability. They said even if you come and you do 10 kilometers or you do 20 kilometers, so which encourages participation. Most of our events, we do have events that accommodate, but they were intentional to say, come participate, whether wheelchair, walking stick, but cover 2 kilometers, you have done your best, do your best. If you do 100 kilometers, and I did 100 kilometers, so if you do 100 kilometers, it's fine. But the key thing is, let's move. Let's move.
Prof, we've only scratched the surface. I have more questions that I did coming in, but it was a beautiful conversation, and I have to let you go because of time constraints. But I think but I think the most important thing that I think we've also just touched on and you've touched on as well was, especially with the research, which I think was on contextualizing exercise.
Yes.
Because a lot of the times we think of exercise as going to the gym, whereas we need to look at the different contexts and say, for this context, how do we go about making it applicable to them? You mentioned gamifying activity and movement, because people like to play games and people like to engage and be social. So how do we integrate and plug in the stress management part of it firstly, like debriefing and finding times to calm down, but also the physical activity component as well in what people unconsciously thinking about. And in the clinics you hear, are you exercising? They'll say no, but they walked 5 kilometers to come to the clinic.
Yes.
And I mean, they're getting a bit of activity there, but if they were to...
A lot of activity.
More than I would, because I drive from home to here, then from here to home to the shops, you know. So, and if we were to just change that perspective from them to say, you are walking, consider this as a form of activity and exercise, and even their frame of mind as, because now they're not thinking, oh, I have to walk all the way to the pen. They're thinking, oh, actually, let me get my 5 kilometers for the day or 2 kilometers, and that's activity on its own. It's time for me to debrief, just watch what's happening around the community, and that helps with the stress level. So you get in the physical component, but also the stress level. But thank you so much for...
Just one more with the walking, because we say when they're walking, they walk to the clinic, we know, then we just encourage them to increase the pace so that they benefit from that as exercise, increase heart rate. So they don't have to now say they're going to jog in the evening. If they're walking that 5 kilometer, just increase the pace. And again, we also need to, in terms of food at Alexandra, where we got a suggestion to say we need to give an example of grocery shopping, because we come in, we say, eat this, don't eat this, and it's not easy for people to follow, and sometimes it's not relevant in that context, in their community. So going in, now we're thinking we need to maybe focus on doing a trolley, because having a fridge, it sounds like too complex. A trolley with examples of items, but then a challenge is we don't want to be promoting brands. So, but you can just have a trolley, but at times we have no choice. But just to give an example of what can be consumed. But the key thing is we need to just keep moving, and we also need to just make sure we take medication. Because there are people who are moving, who are eating right, they don't take their medication. And then if you take herbal remedies, nothing wrong with that, but you still need to take the medication. The doctor needs to know, whoever is looking after you needs to know, let's take the medication and take it right for those who are on prevention, who are not yet at the level of having stroke. Then we can prevent stroke. Because I always say, I'm getting to a point where I'm not interested in trying to have rehab. We will still have rehab, but I'm more interested in trying to reduce the incidence of stroke. We don't want people to have stroke. So let's take the medication daily as prescribed, and we should know that the myth that stroke is because somebody was bewitched. If that's what a person believes, yes, we cannot argue with that, but please take the medication while trying other alternative interventions, because the most important thing is the first 3 months to 6 months are the most crucial, is the most crucial period for rehab if we are to see meaningful results. So thank you very much for inviting me. And I think there's more to say. But the key thing is it has to start somewhere, and I must commend you for starting this conversation, because this is another way of reaching out to the community, creating awareness. I spoke about radio. This is the radio. This is TV now. This is actually... and easily accessible.
It's modern day TV, and I think to the point that you had brought up earlier, it's only we have to understand how people consume information now, and this can be broken down into small clips that will be on social media. And if people are on social media, they can have access to this type of information. Whereas if it was on radio, for example, you missed on that show, so you don't get to get that information. But now it's accessible, it's there. If anyone wants it at any point, the long format will be available, and all the short clips will be there. So
maybe the food examples we must one day come and have. Maybe we do with Dr. Sukome, and then we have examples of what is considered appropriate for prevention of hypertension.
No, thank you so much. No, like I said, we've just scratched the surface, but I think we've delivered quite important stuff. And I think, it's safe for me to say there will be a next time.
Okay, we'll see. Okay, but thank you very much, and keep keep up with this good work.
Thank
All
you.
the best.
Thank you, Prof. To everyone watching, hope you tune in to the next episode and you got valuable information today. We are out and peace.
Thank you.